All right, everybody, welcome back to another episode of Psych Guys Podcast. I'm Dr. Joon Chun, co-host Dr. Logan Noone here with me. We're both psychiatry resident physicians. Today, in this episode, we're going to discuss a video that was put out by popular right-wing conservative political commentator Matt Walsh. This video is titled, "There is an Undeniable Link Between SSRIs and Mass Shootings." And to be perfectly candid, we're not political commentators, but we are psychiatry residents, so we can shed a little bit of insight as far as...
We prescribe SSRIs all the time.
All the time.
Yeah.
So hopefully we have some good insight that you guys will find value in. And without further ado, here we go. Logan, I'm going to play you a few snippets out of this. I think the initial video is about 18 minutes long. So we won't go to the entire 18 minutes, but I did pick out certain segments that I think will spur on some good discussion. So here we go, Logan. So this is talking about the suspect Robert Card. If you guys remember the horrific shooting incident that happened in Maine not too long ago. Here we go. Let me play the video.
So Robert Card, all these news outlets tell us, suffered from serious mental health problems. There were major concerns. He was inpatient at a psychiatric facility just this summer for at least 2 weeks. Everyone from his military commanders to his family knew about this, and therefore these outlets, all of them including Fox, CNN, MSNBC, have the same questions, such as how was he able to access firearms? The laws in place are already supposed to prevent somebody like Card from having guns, so why weren't those laws followed or enforced? And those are very good questions. They need to be answered. We also need to know why Robert Card was ever released from that inpatient psychiatric facility, especially when the U.S. military apparently knew that he wanted to shoot up the base. Several commentators have raised that question as well. But
all right, there we go, Logan. So for that clip, I wanted to bring that up because I wanted to talk a little bit about where he brought up, the question, like, how can these inpatient psychiatric facilities let this guy be discharged, essentially, right? This guy was presumably in an inpatient psych facility for up to 2 weeks, shortly before this horrific incident up in Maine took place. So what is going on there, Logan? I think this is something that we can definitely shed some insight on. What are your thoughts?
Right. I mean, I think this is perhaps every utmost fear of psychiatrists, psychiatric nurse practitioners as well. Anyone who's making the decision to discharge a patient from an inpatient psychiatric facility. Joon, you and I haven't been doing this long, but I've interacted with patients that have made homicidal threats. It's a delicate situation. It's an extremely challenging situation. And what I always kind of think about to make myself, in a sense, feel better about my influence on these situations is that there is no such thing as a crystal ball. I cannot perfectly predict what the future may entail. I think a psychiatrist can certainly identify individuals that perhaps are at increased risk of violence, but can we necessarily predict with certainty that if someone's going to go out and do something horrifically tragic like this? When this person also discharged from the hospital, did they abruptly stop all of their psychiatric medications? Did they engage with the outpatient protocol that we entailed? And I also wonder, so we have these patients who come into typically emergency room facilities first. A lot of times, substances are a portion of their psychiatric disease. They're making wild statements of, I'm going to kill blah, blah, blah because they stole my socks or, something. What? Sometimes they're, very different than that, of course. By day 9, 10, 15 of their admission, they're having very different statements. Perhaps they're responding to the therapeutic environment, the medications they're on, and they keep consistently, in a sense, stating, no, I'm not having those thoughts at this current time. Just because they had those statements at the emergency room presentation, can we hold that person for a month? Can we hold that person for a year? Where does this boundary start to get weird and unethical, right? Can you, like that one movie with Tom Cruise years ago, what was it, like Premonition or something, right? Like, can you arrest someone on a crime that they haven't committed yet? And this is, I think, an issue we're going to be dealing with for the remainder of our careers. I don't have a good answer.
Right. I don't think I have a good answer to this one either because it is an ongoing dilemma, right? But I just want to highlight the fact that you said we're not asked to predict the future. I mean, that is just not something that's possible in this reality that we live in. What we're asked to do as psychiatrists, especially working in the emergency department or maybe an inpatient facility, like this one that this individual was presumably hospitalized in, we're not asked to predict the future. We're asked to do a quality risk assessment. Now, is that risk assessment going to be foolproof 100% of the time? No, of course not. Nothing in medicine is. Nothing in this world is foolproof. Nothing in this world is 100% guaranteed. And that applies for the world of psychiatry as well. And I would argue even more so in the world of psychiatry, because unlike other specialties within medicine, there's no blood work that we can do. There's no imaging that we can take that tells us exactly what this person behavior is going to be in the next week or so. Right? That's just something that's not physically possible, and it's not going to be physically possible going forward. So there's that issue at hand. Also, another thing I think we need to consider very carefully is, of course, whenever we have this incidence, right, it gets highlighted that this person was in an inpatient facility and then discharged. Right. So the underlying premise there is, hey, this person should be kept in the hospital longer. They shouldn't have been discharged. And yes, when you have a bad outcome, of course, we can say that. But I think that we also have to remember that in those moments where we're making those decisions, there's a lot of other people whose stories don't make it to the news media, where people do have their inpatient hospitalizations extended many times against their will. And there's a whole other side of the story. And this is a world me and you are very familiar with, Logan. There's so many people that's had negative experiences because when they show up to the hospital, they end up getting involuntarily committed. They want to leave, but the doctors won't let them leave. And they end up staying for weeks and weeks and weeks. So what happens the next time that individual wants to seek out mental health care, right? They're going to say like, heck no, I'm not going to the hospital. The last time I went, this happened to me. So it's also something that can be a barrier to access to mental health care for the people that are in crisis. And again, of course, in the face of severe tragedies such as this one, it's a very difficult situation, right? But the fact of the matter is we can't predict the future. And when I heard the 2 weeks, what did you think about that 2 weeks, Logan? Because I would say, without knowing anything else about this case, 2 weeks is a little bit longer than average for what I would expect a typical inpatient psychiatric hospitalization to be. Would you agree with that or disagree?
I think we kind of have to disagree. Just because, look, we don't know all of the medical details of this particular case. There are some cases that roll through that where like that person's going to be here and they're probably going to be here for a long time. And then there's definitely other cases that me and you work with where it's like, okay, this will probably be a short stay. Sadly, how much of medical discharges don't always have to do with the decision also of the physician or PA or nurse practitioner, but rather the economics of all of this. Was there any kind of, if this person was exhibiting 7 days in a row of denying homicide ideation, I can't read that person's mind. Is the insurance company going to continue coverage at that psychiatric facility? Well, hey, Dr. Noone, they continuously are denying this homicide ideation. I don't approve. I routinely hear about inpatient psychiatric insurance coverage of 3 weeks. And then if you proceed past that, you have to provide medical documentation, which is an extremely frustrating portion of this job. But did that factor in here? It's all complicated aspects of this picture.
Yeah, very complicated indeed. And I'm just going to add on to what you're saying. You're absolutely right, my friend. There's so much about this case that we are not privy to. So me and Logan deal with this all the time. A part of doing a good risk assessment is having that ancillary information. So many times with a case like this, when we're dealing with a reported threat that an individual is making, some of the questions that I would commonly ask is, hey, do you have a legal history? Have you ever been arrested in the past? Have you ever gotten into a fight? Yes. When was the last time? How many fights have you gotten into your life? What was the worst outcome from a fight? Do you have access to weapons or guns? Right? There's a litany of questions that we ask, and those are important data points as far as when we make a decision on whether or not we should discharge the patient in that moment. But again, very complicated issue. And that's, case in point in the world of psychiatry. As I stated earlier, there's no definitive lab test. There's no definitive imaging. So this is a challenge that's ongoing, balancing the risk at hand versus respect for the patient's autonomy and their sense of humanity and respecting that. All right, Logan, moving on to the second clip. Going to share my screen one more time.
Okay, so roughly a quarter of people taking these drugs, according to that report, are actually experiencing increased agitation. It's not just that the drug failed to solve their problem, the drug actively made their problem worse. Now, none of this is really a revelation. If you look at the labels on these drugs, you'll often find that drug companies come right out and admit it. So here's the label of Prozac, word for word. Quote, all patients being treated with antidepressants for any indication should be monitored appropriately and observed closely for clinical worsening, suicidality, and unusual changes in behavior. The following symptoms: anxiety, agitation, panic attacks, insomnia, irritability, hostility, aggressiveness, impulsivity, and mania have been reported in adult and pediatric patients being treated with antidepressants for major depressive disorder, as well as for other indications.
All right, Dr. Noone. Matt Walsh is saying antidepressants can make things worse, such as agitation, anxiety. What are your thoughts? Is this true or is this false?
I mean, look, it's true. And you know, Matt Walsh, you know, commenting on psychiatric medications, I have interesting feelings about, right? You know, look, if you want to get into the nitty gritty, Mr. Matt Walsh, like Prozac, fluoxetine, is more activating compared to some of its other colleagues in a similar class of SSRIs, selective serotonin reuptake inhibitors. But look, we all, as psychiatrists, all of us practitioners, do need to acknowledge that this is accurate information. This is not, Mr. Matt Walsh is not bending the truth whatsoever. Some of these medicines can definitely create distress in our patients, perhaps what that means. Like he's saying, more anxiety and perhaps more scary. You know, we get taught in medical school a lot of times, or that there is a risk of mania with antidepressants. Interestingly enough, over in Europe, they use antidepressants on bipolar patients a lot more than we do over here. But that's another case for another day. But I think we do need to acknowledge this. Yeah, you know, I'll give a point to Mr. Matt Walsh here.
Yeah, I'm going to give him another point. Those are facts. So antidepressants can, in fact, worsen agitation, irritability, anxiety. This is the exact role of the psychiatric facilities that we have, right? So when we talk about inpatient psychiatric admissions, what is the main purpose? One of the main purposes is to monitor for side effects such as this, the increased anxiety. Yes, that's a very common thing that can happen. So one of the things that we do is, right, we're always taught, especially in an overly anxious individual, you want to start the antidepressants low and slow, even at lower doses than what's recommended per that prescribing information that's found on the box, right? And especially in younger patients, right, the increased irritability, agitation is something that we keep a very close eye on. So typically what happens in an inpatient psychiatric unit is if we do observe some of these negative effects, we do simply make a change, we stop it, you know, we intervene. These aren't issues that we let persist, right? And if you're doing this on an outpatient basis, this is exactly the reason why the standard of care is to start at a very, very low dose. And that's the exact reason why your doctor is going to tell you to follow back up within a few weeks. Generally speaking, you know, sometimes those appointments even sound silly, right? You show up, it's like a 5-minute conversation. It's like, yeah, doc, it's fine. I mean, I've only been taking it a month. I'm good. But there are those rare cases where they can have increased agitation, anxiety, maybe even increased suicide ideation. And that's the exact reason why the standard of care and the follow-ups are structured the way that they are. So facts. All right, so let's move on to another segment in this video.
Antidepressants, as well as other psychoactive drugs, have been a common denominator in many of these killings. Too many to even recount, but we'll recount a few of them. Eric Harris, one of the Columbine shooters, was taking 2 separate SSRIs, Zoloft and Luvox. Kip Kinkle, who murdered his parents before shooting 25 of his classmates, killing 2 of them, was taking Prozac, which is another SSRI. Jeff Weiss, the 16-year-old who murdered 9 people in Minnesota, including his grandfather, before killing himself, was on Prozac. One of his family members told the New York Times, quote, they kept upping the dose for him, and by the end, he was taking 3 of the 20-milligram pills a day. I can't help but think it was too much, that it must have set him off. Another relative said, quote, I do wonder whether on top of everything else he had going on in his life, on top of all the other problems, whether the drugs could have been the final straw.
All right. So basically, you know, he's saying that antidepressants have a role in the increase in mass shootings that we've been seeing. What are your initial thoughts, Dr. Logan Noone?
I mean, I think it's an overly simplistic view of an extremely complicated problem. I kind of think it's like, is this the chicken or the egg thing? It's like, okay, all of these individuals were on treatment. However, is every single mass shooter on an SSRI? Were these individuals on an SSRI because perhaps they were dealing with some significant mental health issues, which actually led to them engaging in these horrific acts? Were there substances involved in these horrific acts? Did the person abruptly stop their SSRIs, which perhaps contributed to them engaging in these horrific acts? Because just so the listener is aware, these medications almost universally in psychiatry, but very particularly to SSRIs, if you do abruptly stop them, you're going to feel not good. So it's a double-edged sword. Both taking these medicines can, as we acknowledged, generate some increased anxiety, increased agitation. They can be therapeutic, but sometimes people can react poorly to them. And you also can react poorly to stopping them. I like how you highlighted earlier, like, this is really why the relationship between the patient and practitioner needs to be so vital and so open. And also, I think when we literally sell these products and prescribe them to our patients, like, hey, look, these are not perfect solutions. I can't guarantee you that this is going to fix your anxiety or treat your depression or whatever. It could help, but we also need to acknowledge it might hurt. So, I think it's a gross oversimplification of saying SSRIs cause mass shootings. I think that's unfair. But for me to also sit here and say, no, they definitely don't, zero chance, I think is unfair as well, too. I think that there's so much gray here, and it's complicated.
Right. I agree, Logan. It's a very complicated issue because why do people turn to violence? I don't think you can ever single out one specific incident or reason why an individual, engages in the type of behavior that they do engage in, right? So I think this question of why are so many mass shooters, on antidepressants, as Matt Walsh is claiming, I think that's just another way of asking the question, like, what are the issues going on in our society that's causing mass shootings to occur at a higher rate, right? Because I think antidepressants is essentially being used as a scapegoat, because antidepressants, like, what the way
are antidepressants not prescribed in other countries?
Right. And they don't have those issues there. That's a great point.
It's like, okay, like, it doesn't that like almost counteract the argument right there? It's like, this doesn't make any sense.
Right. And I think the way I view antidepressants at times is that it's oftentimes a band-aid to a bigger societal ill. Why do we have record amount of individuals in our country that's on antidepressants today? Well, look at our economy, look at our family structure, look at our young people and their ability to secure a mate, a partner, a life partner, right? Look at the global political events that are going on,
increased use of substances,
the increased substance use that's going on in our communities, the lack of, the breakdown of communities, the church, spirituality, the lack of purpose. I mean, there's a plethora of reasons, right, why the mental health of our country is deteriorating. And I think to simply correlate or attribute the increased incidence of violence to simply antidepressant use, I think is missing the bigger picture. So I do agree with you. Another thing I wanted to really point out really quickly, Logan, is a lot of the times this is premeditated violence, right? These aren't random acts. Most of the times, there's like a manifesto. These individuals have been having these thoughts, maybe even planning to a certain degree. And premeditated violence is the single most difficult type of violence to stop, right? There's what we consider like psychotic violence, right?
But some of it does definitely seem psychotic and random and crazy too, right? Like, I think we have to acknowledge that too.
Yeah. So there's unpredictable, there's violence that's due to psychosis. I think if you medicate somebody with antipsychotics, maybe get those auditory hallucinations to stop, we can have a reasonable expectations that we may be able to get those kind of desires to go away. But if somebody has antisocial tendencies, if they're just plotting to do a certain thing, I mean, like I said, psychiatry, there's no lab results saying that this person is lying or telling the truth. If they're willing to stick to their story for an extended amount of time, that risk can slip through the cracks because of how difficult some of this premeditated violence can be to spot out ahead of time.
Right. Right. And almost to like use, because I feel like people listening to this might be like, oh, listen to these goddamn lefties fucking, discounting these SSRIs. And, I'm not necessarily implying that guns are the reason of these mass shootings either, right? I think that also is an overly simplistic view of viewing these mass shootings. I've kind of believed that guns are a tool, and if used improperly, that tool can be recklessly dangerous, of course, right? And we see that with all of these mass shootings. I think that's really the approach we need to take with SSRIs. These SSRIs and other psychiatric medications can be both therapeutic, but we as practitioners need to acknowledge they can also be harmful too. They can increase your anxiety, the what you're experiencing. But me and you also prescribe other medication that sometimes modulates on the dopamine pathway that can increase someone's like risk-taking abilities, and maybe they're gambling more or engaging in like these kind of like sexually wild experiences. Like you could almost extrapolate every single psychiatric treatment could be contributing to this, right? Like we need to look at this, I think, very holistically to even attempt to try to solve this issue. And I think one of the biggest things, like you were acknowledging earlier, it's like, what about American culture in particular is so different than these other countries that we are seeing these kind of mass shootings, because SSRIs are one of the most widely used psychiatric treatments across the globe. They're very cheap, reasonably well tolerated, but they can, of course, have side effects too.
Right. And it seems like the mass shootings or the increase in mass shootings may be a uniquely American issue at this point.
Yeah, sadly it is. Yeah.
That's a great point, Logan. All right, let's get back to our video. I have one final section that I want to review with you. Here we go.
It was just a couple of years ago that the pharmaceutical industry admitted that it has no idea how these SSRIs are even supposed to work. Their basis for prescribing them, the chemical imbalance in the brain bit, that was a myth. And that has been admitted. So what that means is that the people giving these drugs to people, they don't even know exactly how they work or why they work or if they do.
Okay, Dr. Logan Noone. They're saying that we essentially don't know how antidepressants work. Fact or fiction? What are your thoughts?
Fact. I mean, I think that is very, once again, Mr. Walsh, I'll disagree with you on a lot of things potentially. I guess I don't even know exactly, but this one I'll give you. Fascinating and frustrating world of psychiatry. And I wish I could say it was limited to SSRIs, but it's not. I this morning was involved with electroconvulsion therapy, ECT, and for the listeners, these are shock treatments. This is what I'm referring to. It's much more humane than what we did previously in society. It involves anesthesia. You do induce a seizure on the patient, but it is extremely actually safe. How it helps this person with depression or catatonia or other psychiatric disease, we have some theories, but we don't understand. Yeah, our understanding of depression is because of low serotonin levels is, in a sense, an old wives' tale. We don't have that same understanding today. Perhaps because SSRIs increase brain-derived neurotropic factor, maybe that's contributing at play here. I don't really know. Now, I would push back a little bit, though. Just because we simply don't understand something doesn't mean it can't possibly offer some therapeutic value, right? Look at all of the things that are going on in kind of the wild aspects of psychiatry now, like with MDMA, psilocybin, ketamine. We are starting to learn that these things can be very therapeutic for our patients. Why? We don't really necessarily know why. And I'll bring this into other aspects of medicine too. Semaglutide or Ozempic or Wegovy, these medications that originally used to treat diabetes, but now also are having really profound weight loss potential too. We think it's from gastroparesis, fancy word of slowing the gut, but doctors don't fully understand why this is leading to weight loss. Us doctors, I think, do need to kind of get off of our ivory towers or overconfidence, I would say too, and really acknowledge with our patients, like, we don't always fully understand how the body works. We don't always fully understand how these medicines work, but we do understand the potential risks that we're measuring and the potential benefits that we're seeing on patients too, and really need to have an honest conversation with our patients. But Mr. Walsh, I'll give you this point as well. This is accurate.
Yeah, Logan, I think that's one of the important and surprising things about training to be a physician, right? We all come to a point where we recognize that, hey, it's a skill to be able to say I don't know, because many of the times, I mean, I'm hoping that, through all the intensive studying that I'm doing, all the patient care that I'm involved in, that I can become, that the highest level of expertise in every sense of the word. But it is a reality that, like today and also going forward, there are going to be many times where I just simply don't have an answer. And, it's just part of our training to be able to come to terms with that. What I will say, to further add on to what you were saying is, yes, initially, our understanding of antidepressants was, fluctuations in serotonin levels, right? But throughout the subsequent decades and years, we've come to realize that it's a much more complicated biology than just simply serotonin, right? What is the role of dopamine, norepinephrine, right? Our antidepressants are also modulating some of those neurotransmitters as well. And what is the interplay of all these different neurotransmitters? We don't know. And to put it simply, right, they say there's more serotonin transmitters in our gut than we do have in our brains. So yeah, so we don't know exactly how an antidepressant works. However, I also don't think what Matt Walsh is saying, because he's essentially trying to frame this as we have no idea what we're doing, and this is like this big revelation that's come out that's going to discredit the psychiatric scientific community. And that's where I'll push back a little bit, because that is not something that's a revelation. I mean, this is clearly written in the textbooks that we're reading, what we're being taught in residency. Yeah, there is no clear understanding of exactly how it's going to work. We have a general framework to understand it. So yes, we did at a point think it was just fluctuations in serotonin levels, but we hit a point where we're like, hey, these antidepressants take 4 to 6 weeks to work, and that increase in serotonin happens almost instantaneously. So what is that, what is that delay between the onset of action and, the reported relief of symptoms, right? There's something else going on there. So now it's thought that there's not only the change in serotonin availability, but that leads to downstream changes in receptor density in your in your synapses.
Right.
So that's like the leading theory as far as I'm aware of now. Will that theory stand the test of time? I don't know. In like two to 3 years, we may have a completely different hypothesis. But I think it's important to recognize that these theories are exactly hypotheses, and psychiatrists are aware. And I don't think there's any major disagreements within the scientific community when you say that antidepressants are in fact not very well understood at all.
And I think that's how medicine sort of should be. We need to always be critical of our understandings of the theories we have and if they actually hold up to scientific rigor. I kind of look at SSRIs as, I wonder if throughout our career, Joon, if SSRIs are eventually going to be the tricyclic antidepressants or monoamine inhibitors, right? And what I'm referring to, listeners, is old school medicines. I wonder if towards the end of our career, when we have a lot more gray hair than we have now, if, maybe we'll only be using SSRIs for those extremely complicated cases that have failed all of our newer agents. I'm skeptical that newer agents are always better in a sense, but, I think that this is how medicine evolves. We need to acknowledge our unknowns, how our misunderstandings have perhaps failed us in the past. But, while we don't understand always how these SSRIs work, there are also a lot of studies of individuals who have been taking SSRIs who have reported that their depression symptoms have got better, that perhaps their anxiety symptoms have got better, or their PTSD symptoms. Now, is this universal? Does every single person that gets better or takes an SSRI for depression get better? Absolutely not. We fail a lot of these individuals, but some individuals absolutely can have benefit from these medications.
Right. And Logan, me and you have a study stored away reviewing the efficacy of all the different antidepressants. So if you guys would like us to, do a little bit more in-depth episode about the real data between the efficacy of antidepressants, leave us a comment, send us an email. We'd be happy to do that if there's enough interest. Otherwise, I think that was a solid 30 minutes of informative conversation. Logan, I certainly learned a lot, from your perspective. And I think I was so passionate about doing this episode particularly, even though we didn't react to, we only reacted to certain segments. But I think it's important to be part of that conversation regarding the criticisms of antidepressants and psychiatry in general, because I do think there are a lot of criticisms online, and I even see like New York Times articles that are very down-putting of antidepressants, about mental health in general. And as psychiatrists, I do think that we need to be at the forefront of these discussions. And hopefully that we were able to at the very least showcase that there are doctors who are aware and who are in agreement that this is an imperfect science, and who are willing to engage with the other side, engage with some of the concerns that are going on in the medical community. So we'll leave it at that, Logan. Hopefully this was a fun episode for you. Thanks for tuning in, guys. Leave a comment, subscribe, and we'll catch you in the next one.